Welcome to Pediatric Case Review. Today we present a comprehensive case-based review of propionic acidemia for general pediatricians. This is one of the most important organic acidemias in pediatric metabolic medicine, and it represents a true pediatric emergency when it decompensates. We will walk through 14 carefully crafted clinical cases covering neonatal presentation, late-onset phenotype, neurological findings, enzyme defect, pathophysiology, toxic metabolites, newborn screening, laboratory indicators, differential diagnosis, acute crisis management, dietary principles, supplemental therapies, long-term complications, and surgical interventions. Let us begin. Case 1. A 3-day-old full-term male infant is brought to the emergency department. He was born via uncomplicated vaginal delivery with APGAR scores of 8 and 9. His mother reports poor feeding since day 2, progressive lethargy, and repeated vomiting. On examination, he is hypotonic, minimally responsive to stimulation, and tachypneic. Labs show metabolic acidosis, hyperammonemia, elevated anion gap, and neutropenia. Newborn screening result is pending. What is the most likely diagnosis? Option A, propionic acidemia. Option B, neonatal sepsis. Option C, urea cycle disorder. Option D, hypoxic ischemic encephalopathy. The correct answer is option A, propionic acidemia. This is the classic neonatal onset presentation. The infant appears healthy at birth, then deteriorates rapidly within days. The hallmark biochemical finding is metabolic acidosis with a high anion gap. Hyperammonemia occurs because propional coenzyme A inhibits the urea cycle. Hypotonia and lethargy result from toxic metabolite accumulation. Elevated propionylcarnitine, known as C3, on newborn screening is the key screening marker. A critical differentiator from methylmalonic acidemia is that methylmalonic acid levels are normal in propionic acidemia. Neonatal sepsis can mimic this presentation but does not cause an elevated anion gap metabolic acidosis with hyperammonemia. Urea cycle disorders cause isolated hyperammonemia without acidosis. Hypoxic ischemic encephalopathy presents at birth, not after a symptom-free interval. Case 2. A 2-year-old boy was previously meeting developmental milestones. He now presents with loss of previously acquired speech, refusal to walk, and 3 episodes of vomiting following a viral upper respiratory illness 5 days ago. On examination, he has hypotonia, irritability, and mild hepatomegaly. Labs show metabolic acidosis and mildly elevated ammonia. Which clinical phenotype best describes this presentation? Option A, neonatal onset propionic acidemia with hyperammonemic crisis. Option B, urea cycle disorder presenting with isolated hyperammonemia. Option C, late onset propionic acidemia triggered by catabolic stress. Option D, methylmalonic acidemia with renal involvement. The correct answer is option C, late onset propionic acidemia triggered by catabolic stress. In the late onset form, catabolic triggers such as illness, surgery, or fasting precipitate metabolic crises. Symptoms have an insidious onset and may appear months to years after birth. Key features include recurrent vomiting, protein intolerance, developmental regression, and hypotonia. This form often mimics common conditions and is frequently misdiagnosed as gastrointestinal disorders or cerebral palsy. The red flag here is developmental regression after a febrile illness in a previously normal child, which should always prompt consideration of a metabolic workup including plasma amino acids, urine organic acids, and acylcarnitine profile. Case 3. A 4-year-old boy with known propionic acidemia presents with progressive involuntary movements over 3 months. Examination findings include twisting, sustained muscle contractions consistent with dystonia, irregular writhing limb movements consistent with chorioathetosis, mild cognitive regression noted by parents, and no acute metabolic crisis currently. Which finding is most likely on brain magnetic resonance imaging in this child? Option A, periventricular leukomalacia. Option B, cortical atrophy with gyral simplification. Option C, diffuse white matter signal abnormalities. Option D, bilateral basal ganglia signal changes. The correct answer is option D, bilateral basal ganglia signal changes. The basal ganglia are selectively vulnerable in propionic acidemia because they are highly energy dependent. Toxic metabolite accumulation, including propionyl coenzyme A and methylcitrate, disrupts mitochondrial energy production in basal ganglia neurons. On magnetic resonance imaging, this appears as bilateral symmetric signal changes in the caudate nucleus and putamen on T2 weighted sequences. Clinically, this presents as dystonia, chorioathetosis, or acute movement disorders. The pathophysiology pathway proceeds from propionyl coenzyme A accumulation to mitochondrial dysfunction with decreased adenosine triphosphate production, ultimately causing basal ganglia neuronal injury. This energy failure preferentially affects high-demand basal ganglia neurons. Case 4. A 3-week-old male infant is referred after abnormal newborn screening. He has been feeding poorly since day 5 of life, with progressive lethargy and episodes of vomiting. Labs reveal metabolic acidosis, hyperammonemia, and elevated propionyl carnitine, known as C3, on acylcarnitine profile. Urine organic acids show elevated 3-hydroxypropionate and methylcitrate. The metabolic team confirms a diagnosis of propionic acidemia. Which enzyme is deficient in propionic acidemia? Option A, propionyl coenzyme A carboxylase. Option B, methylmalonyl coenzyme A mutase. Option C, phenylalanine hydroxylase. Option D, ornithine transcarbamylase. The correct answer is option A, propionyl coenzyme A carboxylase. This is a mitochondrial enzyme that normally converts propionyl coenzyme A to dimethylmalonyl coenzyme A, which then enters the Krebs cycle as succinyl coenzyme A. The enzyme is biot-independent and encoded by 2 genes, PCCA and PCCB, both inherited in an autosomal recessive pattern. When this enzyme is deficient, propionyl coenzyme A accumulates and is shunted into toxic byproducts, including 3-hydroxypropionate, methylcitrate, and propionyl glycine. The propiogenic substrates that feed into propionyl coenzyme A include the amino acids isoleucine, valine, methionine, and threonine, as well as odd-chain fatty acids. The consequences are metabolic acidosis, hyperammonemia, and cellular energy failure affecting the brain, heart, and kidney as target organs. Case 5. A 10-day-old male infant was identified through newborn screening with elevated propionyl carnitine, known as C3. Confirmatory plasma acylcarnitine profile confirms propionic acidemia. The metabolic team orders urine organic acid analysis to assess the degree of metabolite accumulation. Which organic acid metabolite is most characteristically elevated in the urine of patients with propionic acidemia? Option A, methylmalonic acid. Option B, homocysteine. Option C, 3-hydroxypropionate. Option D, orotic acid. The correct answer is option C, 3-hydroxypropionate. When propionyl coenzyme A carboxylase is deficient, propionyl coenzyme A cannot be converted to methylmalonyl coenzyme A. Instead, it accumulates and is shunted into toxic byproducts. 3-hydroxypropionate is a key toxic metabolite found elevated in urine. It is the hallmark urine organic acid marker for propionic acidemia. It inhibits the Krebs cycle, leading to energy failure and metabolic acidosis. Other key toxic metabolites include methylcitrate, which is found in urine and confirms the diagnosis, propionyl carnitine, which is the primary newborn screening marker found in blood, and propionyl glycine, which is a detoxification product. Option A, methylmalonic acid, is elevated in methylmalonic acidemia, not propionic acidemia. This is the critical differentiator between these two organic acidemias. Case 6. A 3-day-old male infant is well-appearing with a normal physical exam. Newborn screening returns showing elevated propionyl carnitine, known as C3, and elevated C3 to C2 ratio. There is no family history of metabolic disease. Parents are anxious and asking what happens next. What is the most appropriate next step? Option A, reassure the parents, as elevated C3 is a common benign variant and requires no further action. Option B, start empiric protein restriction immediately without further testing. Option C, repeat the newborn screen in 2 weeks as the initial result may be a false positive. Option D, perform confirmatory urine organic acid analysis and plasma acylcarnitine profile urgently with immediate metabolic consultation. The correct answer is option D, perform confirmatory urine organic acid analysis, and plasma acylcarnitine profile urgently with immediate metabolic consultation. The diagnostic pathway begins with the newborn dried blood spot analyzed by tandem mass spectrometry, which detects elevated propionyl carnitine, known as C3, with or without elevated C3 to C2 ratio. False positives are possible from prematurity, maternal vitamin B12 deficiency, and specimen timing. Confirmatory testing includes urine organic acids looking for elevated 3-hydroxypropionate, 2-methylcitrate, and tigloglycine, plus plasma amino acids showing elevated glycine and plasma acylcarnitines. Molecular genetic testing of the PCCA and PCCB genes provides the definitive diagnosis. Remember that elevated C3 is also seen in methylmalonic acidemia, so urine organic acids are essential to differentiate the two conditions. Case 7. A 4-week-old male with confirmed propionic acidemia presents in acute metabolic crisis. He is lethargic and poorly feeding. Labs show severe metabolic acidosis and markedly elevated ammonia. A plasma amino acid panel is sent, which finding is most characteristic of propionic acidemia during acute crisis. Option A, hyperglycinemia, meaning elevated plasma glycine. Option B, hyperalinemia, meaning elevated plasma alanine. Option C, elevated plasma phenylalanine. Option D, low plasma leucine with normal glycine. The correct answer is option A, hyperglycinemia, meaning elevated plasma glycine. Propionyl coenzyme A inhibits the glycine cleavage system, causing glycine accumulation in plasma and cerebrospinal fluid. Elevated plasma glycine is a key biochemical hallmark of propionic acidemia, also seen in methylmalonic acidemia. However, this glycine elevation is secondary, not primary, which distinguishes propionic acidemia from non-ketotic hyperglycinemia. In non-ketotic hyperglycinemia, glycine is markedly elevated but organic acids are normal, and that is the key differentiator. Ammonia is also elevated in propionic acidemia due to inhibition of the urea cycle by toxic organic acids. The comparison table shows that in both propionic acidemia and methylmalonic acidemia, plasma glycine is elevated, ammonia is elevated, and urine organic acids are abnormal, while in non-ketotic hyperglycinemia, glycine is markedly elevated but ammonia and organic acids are normal. Case 8. A 3-day-old male is flagged on routine newborn screening with an elevated propionyl carnitine, C3, level. He appears well, feeding adequately, with no signs of distress. He was born at 34 weeks gestation and is currently receiving carnitine supplementation. His mother had low dietary vitamin B12 intake during pregnancy. Which of the following is the most likely cause of a false positive C3 elevation on this infant's newborn screen? Option A, specimen collected after 48 hours of life. Option B, maternal vitamin B12 deficiency during pregnancy. Option C, full-term gestational age at birth. Option D, absence of carnitine supplementation. The correct answer is option B, maternal vitamin B12 deficiency during pregnancy. When the mother is B12 deficient, maternal propionyl carnitine, C3, levels rise because B12 is required as a cofactor in the propionate metabolic pathway. This elevated C3 crosses the placenta and accumulates in the infant's blood, leading to a false positive newborn screening result. The infant's own metabolism may be entirely normal. This resolves after the mother receives B12 supplementation. Other common causes of falsely elevated C3 include specimen collection before 24 hours due to physiologic metabolite flux, prematurity causing immature metabolic clearance, hyperbilirubinemia from metabolic stress, carnitine supplementation causing exogenous C3 elevation, and true maternal propionic acidemia or methylmalonic acidemia. The key clinical pearl is to always check maternal B12 status before proceeding with invasive workup in the infant. Case 9. A 3-day-old male presents with poor feeding, lethargy, and metabolic acidosis. Newborn screening reveals markedly elevated propionyl carnitine, C3. Urine organic acid analysis shows elevated 3-hydroxypropionate and 2-methylcitrate. The metabolic team is considering two diagnoses, propionic acidemia versus methylmalonic acidemia. Which single laboratory marker most reliably distinguishes propionic acidemia from methylmalonic acidemia? Option A, elevated plasma ammonia level. Option B, elevated urine tigloglycine. Option C, normal methylmalonic acid levels in urine and plasma. Option D, elevated propionylcarnitine, C3, on acylcarnitine profile. The correct answer is option C, normal methylmalonic acid levels in urine and plasma. This is the key differentiator between propionic acidemia and methylmalonic acidemia. In propionic acidemia, propionyl coenzyme A accumulates but does not enter the methylmalonic acid pathway because the enzyme block is upstream of methylmalonyl coenzyme A. Therefore, methylmalonic acid remains normal. In methylmalonic acidemia, the enzyme methylmalonyl coenzyme A mutase is deficient, so methylmalonic acid is markedly elevated. Both conditions show elevated C3 propionylcarnitine on acylcarnitine profile, elevated 3-hydroxypropionate and methylcitrate in urine, and hyperammonemia during crises. The simple rule is elevated C3 plus normal methylmalonic acid equals propionic acidemia, while elevated C3 plus elevated methylmalonic acid equals methylmalonic acidemia. Case 10. A 4-year-old boy with known propionic acidemia presents to the emergency room with vomiting, lethargy, and decreased responsiveness following a febrile illness. Labs show a pH of 7.18 indicating severe acidosis, ammonia of 480 micromoles per liter, which is markedly elevated, and glucose is normal. What is the preferred emergent pharmacologic agent to rapidly lower ammonia in this child? Option A, sodium benzoate and sodium phenylacetate. Option B, high-dose intravenous dextrose infusion. Option C, oral metronidazole. Option D, carglumic acid. The correct answer is option D, carglumic acid. Carglumic acid activates N-acetyl glutamate synthase, which stimulates the urea cycle and reduces ammonia levels. It is used acutely when ammonia is markedly elevated in organic acidemias like propionic acidemia. The acute treatment pathway starts with stopping protein intake immediately, then initiating high-rate intravenous glucose with 10% dextrose to reverse catabolism, then administering carglumic acid. If ammonia exceeds 500 micromoles per liter, add nitrogen scavengers such as sodium benzoate and sodium phenylacetate. If there is no improvement, recheck ammonia and consider dialysis. Carglumic acid is an adjunct to dietary protein restriction and intravenous glucose. It does not replace nitrogen scavengers in urea cycle disorders. Option C, oral metronidazole, is used in chronic management to reduce gut propionate production, not in acute crisis. Case 11. A 4-year-old girl with confirmed propionic acidemia has been metabolically stable on a specialized medical formula. Her dietitian is reviewing her protein prescription. Her current diet restricts certain amino acids that are direct precursors to propionyl coenzyme A. Which group of amino acids must be restricted in her specialized medical diet? Option A, valine, isoleucine, methionine, threonine. Option B, leucine, lysine, tryptophan, phenylalanine. Option C, arginine, glutamine, alanine, serine. Option D, glycine, proline, histidine, aspartate. The correct answer is option A, valine, isoleucine, methionine, and threonine. These are the 4 propiogenic amino acids, and you can remember them using the mnemonic VOMIT, which stands for valine, of methionine, isoleucine, threonine. Dietary restriction of these amino acids is the foundation of chronic management in propionic acidemia. The management goals include reducing propiogenic load by restricting these amino acids to prevent metabolic crises, ensuring adequate nutrition with a specialized propionic acidemia medical formula to maintain growth, supplementing with L-carnitine to enhance toxic metabolite excretion, and reducing gut propionate production with intermittent metronidazole. Foods that must be restricted include meat, fish, eggs, dairy, legumes, nuts, seeds, and standard infant formula. These are all replaced by a specialized amino acid formula that excludes the propiogenic amino acids while ensuring adequate caloric intake. Case 12. A 6-year-old boy with known propionic acidemia is on a protein-restricted diet and specialized metabolic formula. His metabolic team initiates L-carnitine supplementation as part of his chronic management plan. What is the primary mechanism by which L-carnitine benefits patients with propionic acidemia? Option A. It inhibits propionyl coenzyme A carboxylase to reduce toxic substrate load. Option B. It stimulates mitochondrial energy production via the Krebs cycle. Option C. It conjugates with propionyl coenzyme A, forming propionyl carnitine for urinary excretion. Option D. It activates biot-independent enzymes to restore propionyl coenzyme A carboxylase activity. The correct answer is option C. L-carnitine conjugates with propionyl coenzyme A to form propionyl carnitine, known as C3. Propionyl carnitine is water-soluble and can be excreted safely in the urine. This prevents toxic intramitochondrial buildup of propionyl coenzyme A. L-carnitine also reduces secondary carnitine deficiency, which occurs because carnitine is consumed in the detoxification process. The typical dose is 50 to 100 milligrams per kilogram per day in divided doses. The three key supplemental therapies in chronic propionic acidemia management are L-carnitine for propionyl coenzyme A excretion, metronidazole intermittently to decrease gut bacterial propionate production, and carglumic acid for acute hyperammonemia episodes. Case 13. A 9-year-old girl with known propionic acidemia is attending her 6-month metabolic clinic review. She has been metabolically stable for the past year with no acute crises. Her diet is well controlled and she is on L-carnitine supplementation. She appears well, with normal growth parameters. Her parents ask which routine screening test is most important to monitor for a potentially life-threatening complication. Which organ system requires regular screening with echocardiography in all patients with propionic acidemia, regardless of metabolic stability? Option A. Renal system, screening for chronic kidney disease via renal ultrasound. Option B. Cardiovascular system, screening for cardiomyopathy via echocardiography. Option C. Hepatic system, screening for liver fibrosis via ultrasound. Option D. Ophthalmologic system, screening for optic neuropathy via fundoscopy. The correct answer is option B. Cardiovascular system, screening for cardiomyopathy via echocardiography. Cardiomyopathy is a major and potentially fatal complication of propionic acidemia. It occurs even without prior metabolic crises. Both dilated and hypertrophic forms have been reported. Routine echocardiography is mandatory in all patients with propionic acidemia. Cardiomyopathy is a leading cause of sudden death in this condition, and cardiac involvement may even be the first presentation. Other long-term complications include brain involvement with intellectual disability, seizures, and movement disorders, eye involvement with optic neuropathy, kidney involvement with chronic kidney disease, bone marrow involvement with cytopenias, and pancreatic involvement with pancreatitis. Surveillance for all of these is required regardless of crisis frequency. Case 14. A 7-year-old boy with known propionic acidemia has been hospitalized 5 times in the past year for metabolic crises. Despite optimal dietary management and pharmacologic therapy, he continues to have poor weight gain and progressive developmental regression. His latest echocardiogram reveals mild left ventricular hypertrophy. Which of the following surgical interventions is most likely to improve metabolic stability and reduce the frequency of decompensation episodes in this patient? Option A. Bilateral adrenalectomy to reduce cortisol-driven catabolism. Option B. Renal transplantation to improve metabolite clearance. Option C. Pancreatic islet cell transplantation for metabolic support. Option D. Liver transplantation to restore partial enzyme activity. The correct answer is option D. Liver transplantation to restore partial enzyme activity. Liver transplantation is considered in propionic acidemia for patients who have frequent metabolic decompensation episodes, defined as 3 or more crises per year despite optimal therapy, failure to thrive with poor weight gain and growth despite dietary management, cardiac involvement with progressive cardiomyopathy or arrhythmia risk, and neurological decline with progressive developmental regression or basal ganglia injury. Liver transplantation replaces approximately 50% of propionyl coenzyme, a carboxylase activity, and significantly improves metabolic stability, reducing the frequency of decompensation episodes. However, it is not a cure. Neurological and cardiac risks persist after transplantation, and lifelong multidisciplinary follow-up continues. Before we move to the final summary, here is a quick note about our Pediatric Case Review community on Patreon. In our community, all videos are systematically organized by body system for easy navigation, so you can access every lecture in one place. All presentations are also available as downloadable images, perfect for offline study and practice of all questions. If you are interested in details and how to subscribe, simply comment below in this post, and we will message you directly. Here are the 5 key clinical takeaways that every general pediatrician must remember about propionic acidemia. Number 1. Suspect propionic acidemia early. Poor feeding plus lethargy plus metabolic acidosis in a neonate equals urgent workup. Number 2. Elevated C3 means urgent action. Abnormal newborn screening propionyl carnitine requires immediate confirmatory testing plus metabolic consultation. Number 3. Diet is foundational. Restrict propiogenic amino acids. Use specialized formula and supplement with L-carnitine. Number 4. Multi-system surveillance is essential. Monitor for cardiomyopathy, seizures, renal disease, and optic neuropathy with lifelong monitoring. Number 5. Transplant is not a cure. Liver transplant reduces crises, but complications persist, and lifelong care continues. Follow Pediatric Case Review for more case-based lectures, and drop your questions in the comments. Thank you for joining this Pediatric Case Review lecture on propionic acidemia. We appreciate your time, attention, and commitment to better pediatric care. These lectures are for educational purposes only and do not constitute medical advice. Always consult current guidelines and specialists for clinical decisions. Please follow our channel for more case-based pediatric lectures. If you have any questions or topics you would like us to cover, comment below and we will be happy to hear from you. See you in the next lecture.